Okay, I report my technique that I use now before to do a reverse prosthesis. The key point is to analyze the deformity on the glenoid because it's more difficult to implant a reverse prosthesis. So you have to analyze the inclination, and this is the classification of Luc Favard. On the classification, the new classification of Gilles Walsh, and you see that the tip D is very dangerous because this is an anteversion of the glenoid and you have to correct. On B3, this is a big retroversion. Be aware E3 and E4 because the risk is to implant here with a superior tilt. So, what do you use? You use standard X-ray, 2D CT scan, 3D CT scan with OROS. This is a system that everybody can use, or automatic system with a 3D CT scanning. So systematically we do a CT scan, and I think that is very important to measure the beta angle or the reverse angle. Depends of the size of your prosthesis. If you use a very small prosthesis at the inferior part of the glenoid, I think that the most important is to measure the reverse angle, because you have to obtain an inferior tilt. You see that you have to rim inferiorly, and after you put a bone graft superiorly to obtain inferior tilt. And I think that I agree with Pascal, if you use a small base plate, it's not useful to measure the beta angle. So regarding the retroversion, you can use axillary view, but it's not very precise for me. You can use with the papillon technique the degree of posterior subluxation with this measurement, and you know that this is a definition of B1, B2, B3 and C, that there is a posterior subluxation of the humeral head. So 5 years ago I used a 2D CT scan and I tried to measure the deformity in 3 planes, and I tried to correct the deformity. It's very important to imagine where you will implant the center of your prosthesis, and you can reproduce on sagittal view, coronal view, and frontal view the same point. It's the reason why you design the blue line on the other line to define 15 millimeters the center on the inferior part of the glenoid. So we do this measurement and we try to apply this measurement on the coronal view, on the frontal view, to define the degree of retroversion. And in this case, we have 26 degrees of retroversion at the level of the center of your base plate. I think it's very important because you know that the deformity of the glenoid is very complex. And you have to refer the center of your future base plate in the 2 plane, version and inclination. And with this system, I measure 26 degrees of retroversion and 84% of posterior subluxation. So after you correct, what are you doing? You have many possibilities. The more simple is to rim anteriorly and to put a bone graft posteriorly to correct the retroversion, to do a metallic augment or polyethylene augment if you do anatomic arthroplasty. We use a guide with a wedge posterior augment, and after you follow the Kirchner wire. So you do the same for the inclination. You define the line of the supraspinatus, and after, if you use a small base plate inferior to this line, you try to correct. If you have 10 degrees of, if you want 10 degrees of inferior tilt, you have to rim 8 millimeters, and after you put a bone graft superiorly. I think with the system it's not so bad because you are more precise that if you don't use any guide. You had 6 mm superior bone graft, and systematically we did this technique 5 years ago. So after you use ORO software, because we prove that the 3D reconstruction is more precise than the 2D reconstruction, and we try to do three points. You see that the point medially, superiorly, inferiorly to measure the retroversion and the inclination. So now we use automatic segmentation, and we send the CT scan to the engineer, and the engineer does a segmentation. You remember this paper of the team of Luc Favard. Berway was in New York in the biomechanical, he did a biomechanical study, and he reported this result of 30 CT scan reconstructing 3D models with 3 points. A center point to the glenoid, medial point to the supraspinatus, and distal point. And the conclusion was very interesting because they implanted virtually the glenoid component, a series with all the scapula, a good definition of all the scapula, on another series only the surface of the glenoid. And it was very significant that if you use all the scapula, it's better to have the good position of the glenoid component. So another problem is that you use a different system of reconstruction of 2D to 3D. And for example, Patrick Denard compared IMASCAP and VIP, and there is a difference of version in 7 cases and in 12 cases, more than 5 degrees of version. It's a lot. It's more than 10 degrees is 11%. And this is the same difference in inclination. And of course, when you use your software, you have not the same version that another software, and this is a problem for the future because I don't know what is the truth of the version on the inclination. So I use this system with 3 points. We have many points in the center, and we send, and this is a video here. This is a video, okay. And the engineer will send you on your website the reconstruction of the scapula and the humerus in 2D reconstruction, and you can remove the humerus. And with the system, I think it's very nice because you can evaluate the osteophytes, and superiorly, inferiorly, you can move the scapula as you want, and after you define the point to measure the version and the inclination. After you can put the prosthesis, you have many possibilities, 44, 46, you can do anatomic, you can do reverse, and you check systematically and simultaneously on the coronal plane and sagittal plane. And it's very important because you can move anteriorly if it seems that it's too posterior to avoid the perforation of the scapula, and you can rotate, and you see that the version of this patient is 8 degrees of retroversion and a superior tilt on 11 degrees. It's clear that we have to correct this position if you want to respect the academic rules of the reverse prosthesis. You calculate the seating of the prosthesis, you see, and after you calculate the retroversion, you see that you have the guides that you use systematically. This is not a PSI, you have a reasonable guide, and you see that you evaluate the quantity of bone graft superiorly. Very interesting. If you do a rotation, you modify the version and you modify the inclination because this is a 3D reconstruction. It's very different than the 2D. And it's important that if you rotate your metal back on the glenoid, you modify the version on the inclination. And you can do a big mistake, I think that. And after you try to evaluate where you have to put bone graft, you see that the seating is 58%, is many times enough because there is a good press fit. And after you can measure the screw that you will use. And the screw is important, the length, because you have to perforate the cortical bone to have a good compression of the base plate. And there is a risk for the suprascapular nerve, and you can identify the position with the suprascapular nerve here. and you have many choice. And after you finish, and you validate if you are very happy about the position of your prosthesis, you validate, and you have a PDF during the operation. I show the PDF that and you take your PDF on the operating room, and after you follow that. You have the patient, you have the size of the glenosphere, of the metal back, you are the guide, you see that you have to put 10 degrees of version, 20 degrees of retroversion. And this is, and after, I did a CT scan systematically of all my patients. On my first 30 patients, I had a variation of 1 to 3 degrees on the CT scan if we compare with the preoperative planification. So the second problem is how to reproduce better the preoperative planning. PSI is very expensive, it's very nice. Preoperative navigation, I think, is very good. My friend Florent does with Exatech, and I think it's a good way. And we decided to use glenoid guide reusable. But I don't know what is the best way. So first conclusion that we progress. Is it necessary to do preoperative planification? Yes, and I think you have to do systematically, not in a complex cases. Systematically you have to do, because if you want to respect the academic rules, inferior tilt, inferior glenoid component, it's better with a preoperative planification. We have to measure, of course, inclination on retroversion, and 3D reconstruction is definitively more precise than 2D CT scan. So the question now is, we have many software to do. We have not the same information. We have no perfect tools to reproduce the preoperative planification, but we progress every day. And I think that is not yet enough evidence-based, but is good for the education on the reproducibility of your surgery. Thank you a lot for your kind invitation. It was a pleasure to spend 3 days with you.